Hi, today I am going to discuss first trimester screening and nuchal translucency ultrasound. Now, the objectives of this presentation is to be able to review and identify first trimester screening, define nuchal translucency screening alone as well as in combination with other testing, review the history of first trimester screening, be able to identify abnormal and normal results, and then review and identify appropriate patient education and follow-up. Now, a little bit on first trimester combined aneuploidy screening. This is performed between weeks 11 and 14. It includes an HCG, a pregnancy-associated plasma protein A, which for short is the PAPP-A, and then nuchal translucency ultrasound. Now, a little bit on the serum testing. The HCG is a chemical that's created by the trophoblastic tissue, and it's found in early embryos. Now, the quantitative measurement can help determine age of the fetus, assist in diagnosing abnormalities such as an ectopic pregnancy, molar pregnancy, possible miscarriage, and is used in the first trimester for screening for genetic conditions such as trisomy 21. PAPP-A is a protein produced by the placenta, which is needed for implantation process and to maintain a healthy placenta throughout pregnancy. Now, I found this chart on UpToDate. I just thought that it was a really good picture of where you would see those first trimester markers in association with which condition would be an increased risk. So, for instance, I won't go through all of it, but with Down syndrome, you will see an increased nuchal translucency, a decreased PAPP-A, and then an increased HCG. Now, with first trimester ultrasound screening, there's 3 types of ultrasounds that can be completed, and generally these ultrasounds can be completed at around 6 weeks, where you can see the intrauterine gestational sac and as well as embryo cardiac activity should be present at 6 weeks. So there's a standard ultrasound, the nuchal translucency ultrasound, which this presentation will primarily be on, which is completed between weeks 11 and 13, and then a detailed first trimester anatomy scan, which can be done between weeks 12 and 14. Now, some reasons why ultrasounds are completed in first trimester are listed here. Couple highlights: confirm pregnancy, estimate gestational age, assess for any uterine abnormality, assess for suspected ectopic pregnancy, vaginal bleeding, pelvic pain, and then there's a couple other reasons that are listed here for your review. The components of ultrasound screening, so what you're essentially looking for, gestational sac size and location, the embryo yolk sac identification, crown rump length, gestational age assessment, fetal cardiac activity, anatomy assessment, nuchal translucency, and the overall maternal organs. And then some recent additions is that you're looking at that fetal size, umbilical cord insertion into the ventral wall, and then the presence of fetal extremities. Now, nuchal translucency ultrasound. This is an ultrasound that is performed at weeks 11 to 14, and it measures the maximum thickness of the subcutaneous translucent area that's between the skin and soft tissue overlying the fetal spine at the back of the neck. Used in compound with first trimester maternal serum screening as well. And when you measure, you want to measure the fetus in mid-sagittal plane. And when it's increased, there's an increased risk for fetal aneuploid, which is either various genetic conditions such as trisomy 21 and 18, as well as heart defects. For normal findings, the crown rump length is between 45 to 84, and the nuchal translucency should measure below 3 millimeters. If it's greater than, then that's associated with a increased risk for fetal genetic abnormalities. This can also be helpful just to differentiate between cystic hygroma, which this appears on ultrasound, mostly in the space behind the neck, but it also extends to the back of the head, whereas nuchal translucency really mainly stays at the back of the neck. And the aneuploid risk is 5 times greater when there is a first trimester cystic hygroma than with an increased nuchal translucency. And it's important to note that this is not a diagnostic test. It is a screening test where you would want to do further diagnostic tests if this is positive, which I'll go into a little bit later. Now, just a little bit on screening history in the first trimester. So it's really greatly improved since 1980, where prior to that, the main method to identify risk was based on the concept that there's an increased risk for genetic abnormalities for fetuses when there's advanced maternal age. In the 1980s, scientists started assessing the risk with maternal serum, specifically in the A-fetoprotein in the second trimester, which led to combination triple screening in the second trimester. And then in the 1990s, Professor Nuchal observed that the fullness of the neck in Down syndrome neonates in the second trimester ultrasound, and he hypothesized that an increased nuchal translucency in first trimester could be a marker for these conditions. Which then led to studies that were conducted that did confirm that increased nuchal translucency did have increased risk for chromosomal abnormalities, and then this led to the first combination of testing, including nuchal translucency, HCG, and PA-PPA. Now, current recommendations by the ACOG is that every patient should be offered first trimester screening, and there's no contraindications to this screening. And I put this really great chart from the ACOG website itself that looks at prenatal genetic testing and when it should be completed. I will upload this PowerPoint as well so that you can have a bigger view of this chart here, because I know it can be kind of hard to see. And then also when there is abnormal testing, the should be further diagnostic testing that is with the CVS, as well as an amniocentesis should be recommended and offered to patients regardless of their maternal age if there is a positive first trimester screening. Now, the sensitivity, a nuchal translucency alone on average detects around 70% risk of fetal risk, for trisomy 21. And then with the combination screen, it detects around 80 to 84%, and both have a false positive rate of 5%. So you can see here that the combined screening is really great to be doing versus just the fetal nuchal translucency alone. I also found this chart on UpToDate, which shows the increased percentage of the nuchal translucency and as it kind of progresses through pregnancy. So about 90% of the pediatric outcomes are a positive, and there's a 5% of fetal or neonatal death. So that's just kind of a nice chart there. Now, indications for screening of genetic abnormalities is to confirm viability, date and confirm the due date. So, this could be certainly important when there's a patient that has a irregular period, assessing early fetal anatomy, checking the position and development of placenta, measuring the nuchal translucency, screening for prior pregnancy with fetal abnormality, and then bleeding in early pregnancy. Now, the procedure of nuchal translucency screening, there's actually a great text table in our textbook that goes over, what you're looking for on the ultrasound. So as I mentioned earlier, the fetus should be measured in the mid-sagittal plane with the nasal tip palate visible, and the margins of the needle translucency at the edge are visible. And majority of the image should be of the fetal head, neck, and upper thorax. And the head should be lying in a neutral position. So you don't want the head to be flexed or hyperextended. Now, I found this checklist and criteria from the Journal of Fetal Medicine, which goes over a little bit more detail of what you should be looking for when you're doing the nuchal translucency ultrasound. Now, advantages and some disadvantages of the testing. Advantages are that results are available in the first trimester. It can help with early detection of increased risk for fetal abnormalities. And nuchal translucency testing alone can be helpful with multiple gestations because the serum testing can be less accurate. And this also can help detect trisomy 18 and trisomy 13. Now, the disadvantages is that alone it only detects about 70% of the increased fetal risk for trisomy 21. There is a false positive rate of 5%, so certainly there's some room for mom to be a little worried if there is a positive screening and then she goes into further testing. And then it does not screen for neural tube defects. Now, findings, I found these two images here from the fetalmaternalmedicine.org. A normal finding is a nuchal translucency less than 3 millimeters and a crown rump length 38-45 to 84 millimeters. So you see here in the picture that you can see the nasal branch, there's a small arrow, and then the small nuchal translucency at the bottom of the image. Versus the abnormal findings shows a nuchal translucency measurement of greater than 3 millimeters or 99 percentile for the crown rump length. So you can see here there's a lot larger of a area on the right versus the left, showing the abnormal result. Now, what you do when you have this abnormal result is you should offer the patient a detailed ultrasound, consider fetal echocardiogram, and if the nuchal translucency is at least 3 millimeters, and certainly if it's greater than 3.5 millimeters, there should be genetic diagnostic testing via amniocentesis or CVS sampling. And this should be performed between weeks 18 to 22 weeks of gestation. Now, if the patient declines primary and secondary screening, then you should offer free cell DNA testing as well. In this chart I found here just kind of goes over if there is a positive testing, what you do. I just kind of found this a nice visualization. And then teaching for your patient, you would want to educate the patient on what nuchal translucency screening is with combination screening, so that would include the serum markers. Educate the patient on normal and abnormal findings and what next steps would be if there was an abnormal finding. Same with normal findings, but certainly if there was an abnormal screening. And then ensure questions are answered for the patient. There certainly is a little bit of a waiting time from getting that. If the patient gets the ultrasound at 11 weeks and then they don't do their diagnostic testing till 18, that can be a really long time for the patient. So just making sure that you answer all their questions, they understand what the screening test is for, and then the patient feels comfortable moving forward with the plan. And then genetic counseling for abnormal findings. And then here's my references.